Good afternoon, good evening once again, and thank you, Arun, for taking definitely a very tough kind of a quiz. I think my talk will give you only 70 to 80% of answers out of that. 20% is still out of the course. And thank you, Saptarishi and Pawan and Kaisar for being there. I think the topic is definitely something which I know it may be very close to the heart of gastroenterologist and hepatologist, but today it may be a change for you to have this thing talked from endocrinologist talking about your topic, but definitely for our students and those endocrinologists practicing, it may be of insight from endocrinologist view on NASH. So with this, let me start. When we talk about this particular topic, I think I would say like it is a continuum. It is not like one thing what we are basically targeting at. So what we are looking at is a non-alcoholic fatty liver disease. So that is a big spectrum of a problem what we are actually dealing with. And if you look at the worldwide population, almost around 25% of the worldwide population has been affected by non-alcoholic fatty liver disease. We have limited data from India, the couple of study from ICMR and the SPRINT study which have been done in India. And again, in those we have found the numbers which seems quite similar to that. And probably in the SPRINT study, it was almost around 56% of adult Indian, they had fatty liver. But if you look at the continuum or the spectrum, basically what you will see over here is you have steatosis, that is a fatty liver without inflammation or hepatocyte ballooning, that you may call it as NAFL. It progresses to the next stage, that is steatohepatitis or NASH, where you have a fatty liver with inflammation and hepatocyte ballooning. Now this NAFL gets converted into, or it progresses to NASH, and almost from this 25%, like the incidence would be, the prevalence would be something around 6 to 7% of people will have NASH. Now why NASH is important? Because the NASH progresses to further increase in cirrhosis, increase in fibrosis, leading to cirrhosis and hepatocellular carcinoma. Now, if we look at, like already Dr. Kelser already told, like it is one of the important indication for liver transplant. And specifically, if you are looking at people who are less than age of 50 years, this is probably one of the important reason for liver transplant. NASH and cryptogenic cirrhosis is one of the important reason, and it is just above HCV infection for liver transplant in this young patient. Not only this, the fatty liver is not benign. The mortality associated with isolated steatosis and NASH, which you can see it is progressively increasing. If there's no NAFLD, the liver-related mortality is quite low. If there is a NAFL, that is only steatosis, you can see the liver-related mortality is high. But if it is NASH, you can see it increases to great extent, suggesting that the NASH also leads to liver-related mortality as well. Now let's take an exemplary case over here. This is a young lady who has come for a routine checkup to one of our clinic. She's working in bank and has a sedentary kind of a lifestyle. She underwent an annual health checkup. That's a routine thing. A young person working in a bank, they have an annual kind of a health checkup, and that is how they go to a healthcare facility and they get themselves tested, and on evaluation found that she is obese. BMI is 29.8 kilogram per meter square. Blood pressure again mildly elevated, 154/90. There's no family history of diabetes, hypertension, dyslipidemia or cardiovascular disease, and she's a known case of hypercholesterolemia for last one and a half year, and she has been taking 10 milligram of rosuvastatin on a regular basis. Now, with this kind of a background on an annual health checkup, we get these laboratory parameters. We find that fasting glucose is 160 milligram per deciliter. Postprandial is 220, definitely suggesting that she is diabetic. HbA1c is 8.2%. She has been on rosuvastatin 10 milligram. So you find that LDL cholesterol is 110, HDL is 35, total cholesterol is 200. However, we find that triglyceride is 220, which is high. eGFR is 90. But her enzymes, ALT and AST, done. ALT is 90 and AST is 110. So she has liver enzyme abnormality, and along with that, she has dysglycemia as well as dyslipidemia at this particular point of time on regular evaluation. And she is a patient who has been subjected for abdominal ultrasound. And these are the kind of images given by the radiologist and saying that she has few signs, hence graded as mild fatty liver. Now, in this particular patient, typically what we see in the ultrasound is a bright liver. The echo texture is increased as compared to the kidney, and there is a vascular blurring. Now, most important thing, the catch over here is how reliable is ultrasound in diagnosis of NAFLD. So it is very, very important that changes consistent with NAFLD may not be detected if less than 20 to 30% of liver contains fat. So the milder cases of NAFLD may not be picked up on regular ultrasound, and ultrasound finding of a fatty liver cannot be distinguished from those of early cirrhosis. So either it is cirrhosis because of something else, or it is NAFLD cannot be distinguished just based on a sonography. So sonography is one of the very important part because that can be easily done in a routine clinics, but we need to understand that it also has the other way that it may be some other cause for that. Now, if we talk about the clinical presentation of NAFLD, most of the patients, they are asymptomatic, or few of them may complain of some fatigue sometime. It is often an incidental finding, incidental abnormal liver enzyme, or incidental bright liver on imaging, or incidental hepatomegaly. And the common scenario is that if patient is going for annual health checkup, annual review for insurance or for occupational health checkup, or annual review in type 2 diabetic patient, or somebody who is dyslipidemic, or in a hypertension clinic, or somebody who is already on statin and we have been monitoring those patients on a regular basis, we may find this abnormality. And once we find this abnormality, it becomes almost necessary to do at least an ultrasound, and if required, to go for further testing. Important thing over here is to exclude other etiologies for this problem. What can be because NAFLD is a diagnosis of exclusion, we need to rule out the other causes of steatosis. And the other causes of steatosis may be alcohol, hepatitis C virus, typically genotype 3, lipodystrophy, certain medication, malnutrition. There can be certain hereditary disorder where steatosis can be there, like Wilson's disease, hypobeta-lipoproteinemia, and lysosomal acid lipase deficiency. So it is very important that we rule out this disorder before we stamp patient as non-alcoholic fatty liver. Now, once we have done that, we have excluded, the second important part becomes is to identify the risk factor for NASH. Now, why I started with NAFLD? Because that is a kind where you are going to pick it up, and then we have to find the risk factor so that they don't progress to NASH. There has been kind of association between NAFLD, NASH and diabetes, and it is bidirectional, because most of the endocrinologists, what they would be seeing would be either obese patient, diabetic patient, or patient with metabolic syndrome, and where the chances of having NAFLD would be pretty high. Patient with NAFLD, NASH, they have increased risk of developing diabetes. There's synergistic increase in the risk of diabetes when combined with obesity or insulin resistance. Patient with obesity, NAFLD, or insulin resistance each have 2 to 4 times increased risk of diabetes. But patient with all three, they have 14 times more risk of diabetes. And there's a high prevalence of diabetes, which has been noted in most of the studies. And patient with diabetes, they have increased risk of NASH with family history of diabetes, increased risk of dying from cirrhosis, which is there, up to 3-fold increased risk of dying from chronic liver disease, mostly attributed to NAFLD. And there's an increased risk of chronic liver disease, which has been seen in most of the study. So there's a bidirectional kind of relation between NASH and diabetes, NASH leading to diabetes and diabetes leading to NASH. So that kind of relation is there. Now, what happens like if you look at people with NAFLD, out of them around 70 to 75% they may have isolated steatosis, and they may be steatosis with mild inflammation, and they may keep on ranging between that. There may be around 25 to 30% of patients with NAFLD on histological, they will have NASH, which may lead to further fibrosis and cirrhosis of the liver. But what is happening is the changes in the fibrosis which may happen. Like 40% may be a stable kind of patient. Around 20% they may regress over a period of time, and around 30 to 40% they may progress. So both the things can happen. They may remain stable for a long time. So it is not the natural course is same for each and every patient. Few of them they may remain stable, and few of them they may regress also. But chances of progression are equally or quite high to progress to worsening of the disease over a period of time. So what are the clinical predictor of NASH in patient with NAFLD? So there are certain things which are there, probably suggest that they may progress to NASH. So one of the important characteristic would be advanced age. As the age is increasing, the greater duration of disease is there, and the longer duration of NAFLD, more chances of developing NASH is there. Sex, the postmenopausal women experience accelerated disease. Why? Still that portion is not very clear from the literature, but in postmenopausal women, there may be some acceleration of the disease. Race, increased prevalence severity typically seen amongst Hispanics and Asian patients. So amongst Indian also, there may be an increased prevalence, or the severity may be high. Hypertension, central obesity, dyslipidemia, insulin resistance, diabetes. If you have a typical consortium of metabolic syndrome, they are more likely to develop NASH. So the risk increases with metabolic syndrome, almost 66% prevalence of bridging fibrosis if older than 50 years of age and obese or diabetic. So if you have this kind of multiple problems, they are quite likely to land up in NASH. AST-ALT ratio more than 1 and low platelet is indicator of NASH cirrhosis. So very important thing on the part of the quiz. Again, like this ratio more than 1, which is quite indicator, and persistently elevated ALT can be associated with greater risk of disease progression. So these are quite a few important clinical predictor where you would be doing all this regular testing, like for checking the blood pressure, checking for the lipid profile, checking for the insulin resistance or diabetes, checking the liver enzyme. So by simple kind of laboratory testing, probably to great extent, we can clinically predict what are the chances of the person landing up in NASH. Now, once we have identified few of the risk factors, it will be very important to assess and quantify the fibrosis, for which the blood and the imaging markers would be needed. Now, very important part is that we always rely on the laboratory test. Now, a normal liver enzymes do not rule out NASH. So it is very, very important that NAFLD, a common diagnosis in patient with incidentally abnormal liver enzyme like ALT/AST. However, liver enzyme may be normal in almost 80% of NAFLD patients. So very important thing and very important take home message that if you find that SGPT, SGOT are normal and you say that no, you can't have NAFLD because your enzymes are normal, mind well 80% of them still can have NAFLD. ALT/AST are not sensitive for NAFLD NASH. Poor correlation between ALT and histology typically which has been seen. ALT typically decreases with advanced fibrosis. As NASH progresses, AST-ALT ratio may increase. The histology severity is similar in NAFLD patient with normal versus abnormal liver enzyme. So again, like everything do not correlate, though it is a very important, like if you find abnormal enzyme, the chances are pretty high. But if you find a normal enzyme, still person can have disease. That is very important take home message. Now let's talk a bit about the tools for diagnosis of NAFLD. Important thing would be the liver enzyme like gamma glutamyl transferase. The sensitivity is 63%, specificity is 65%, not reliable for diagnosis. Ultrasound, again, like sensitivity 85% and specificity of 94%. It is inexpensive, accessible, but cannot distinguish fibrosis, steatosis. So it is better in morbid obese, but again, like it has some ifs and buts. And again, if you go for a CT without contrast, again the sensitivity may be close to 80%, specificity of 97%. It is better for a morbid obese kind of a patient and certain patient where it has been affected by iron fibrosis. So those kind of patient, again, it may be of some help. It also helps to detect mild steatosis, quantify hepatic fat more accurately. MRI, again, it is quite important because it gives more sensitive kind of a cutoff typically. And you have MR spectroscopy, which is pretty sensitive as close to 96% and specificity close to 100%. However, with all this thing, liver biopsy, that is a gold standard, but it is invasive and subject to sampling error. So this is very important and summary kind of diagnostic tool for NAFLD. So liver enzymes and standard imaging modality cannot distinguish NASH from non-NASH NAFLD. So that is again very important part, and the liver biopsy, that is the gold standard kind of a test for confirming NASH. Let me talk a word about pathogenesis of NASH. This is I'm going to go in very much brief because the time is very stipulated for the talk, because I have to discuss the other part and the treatment also. So just to have a bird's eye view on pathogenesis, typically what you have is most of these patients, they are either obese or they have metabolic syndrome. And because of metabolic syndrome or obesity, they also have insulin resistance. Insulin resistance directly and through different modalities can have a kind of effect on the hepatic synthesis of free fatty acid, as well as decrease hepatic oxidation of free fatty acids. As well as in obese patient, there is a decrease in the adiponectin. This was probably one of the questions posed by Arun. So there is decreased adiponectin, as well as you find that there is also leptin resistance. Leptin levels are high. And again, insulin resistance also have effect on adiponectin leptin levels. And again, low adiponectin and high leptin also has a direct effect on the hepatic oxidation of free fatty acid as well as hepatic synthesis of free fatty acid. So this increase in the free fatty acid typically leads to lipid accumulation in the liver, and which leads to reactive oxygen species and leads to liver inflammation. As well as at the same time, there is hepatic stellate cell activation, and which leads to fibrosis, and that is how you land up in cirrhotic kind of liver in these kind of patients. A word about the nuclear receptor, that is a fine-tuned for lipid and carbohydrate metabolism. There is a nuclear receptor subfamily, typically over here, the RXR, and which you have in that family, the PPR alpha, beta, gamma, then you have liver X receptor, alpha, beta, then you have FXR, that is fascinoid acid receptor, alpha. And why it is important, because furthermore, when we go in depth about the treatment part, the treatment is basically focused on PPR receptors or on the FXR alpha agonists. So by modifying those receptors, some of the treatment modalities have been used. So how, like, what are the factors like how do we identify or what are the clinical decision aids to identify the risk of advanced fibrosis. So what you have is an NAFLD fibrosis score, the free calculator that is available on the net. And for the score, you require certain things like age, sex, then the liver enzyme levels, the platelet, and so certain factors are required. Once you fill it, then you'll get the NAFLD fibrosis score based on that. Then you have fibrosis 4 index, that is FIB4 index. That is again free calculator available on the internet. Also, there is vibration control transient elastography. That again, it requires a referral because it takes a bit of time in doing the procedures. So either hepatologist or the radiologist may be doing this test. So, and the risk factor highly associated with NASH includes the metabolic syndrome and the components of that. And based on this score, probably can determine whom to refer for biopsy. So there are non-invasive imaging method and there are invasive kind of a method. So typically, if you look at the non-invasive, it may be the ultrasound or the MRE, which may be done, and typically you get a different kind of picture, which may help in assessment of liver fibrosis in NAFLD. So typically, if you look at the magnetic resonance elastography, you can find out the stiffness, and you can see in this colorful images, like if there is a fibrosis, you get this yellow and the red, which suggests there's a increase in the fibrosis. The stiffness is high, suggesting that the fibrosis is more. So it has a higher diagnostic accuracy for fibrosis versus transient elastography. And inflammation can increase stiffness in absence of fibrosis. That is again very, very important part. So the important tool what has been used is vibration control transient elastography, and where a fibroscan has been done and the value which has been in kPa, that is the pressure unit. Typically they check, and if it is between 6 to 8, probably it suggests that there is a F1, F2 kind of a stage. If it is 8 to 12, that is a bridging fibrosis, and if it is more than 12, probably suggests there is fibrosis. So probably the vibration control transient elastography, it is accurate in detecting advanced fibrosis, and it is most reliable in ruling out advanced hepatic fibrosis with the negative predictive value stronger than positive predictive value, and it predicts the risk of compensation and complication, correlates with the portal fracture. What is the role of liver biopsy? So again, it is very, very important, and it is very important thing, like as you see a patient with NAFLD, which patient to consider for biopsy, it is probably $1 million question, because patient will go from endocrinologist to gastroenterologist or hepatologist, or may go to his general physician or a general practitioner, and then to decide and which are the patient where will consider for biopsy. Since NASH is a histological diagnosis, it probably requires biopsy. And based on the biopsy only, we can say that patient has NASH or not. So typically, if we are doing a biopsy, typically you look for the steatosis without inflammation, ballooning, or fibrosis, that is NAFL. And even there can be mild inflammation in NAFL, but if they have steatosis with lobular inflammation, ballooning, and there's a perisinusoidal fibrosis, probably you can say that patient has steatohepatitis or NASH. And probably that is the thing. And again, based on this biopsy, you can have a different kind of a scoring system. And based on that, you can decide how to go further ahead in such kind of patient. So this is like probably how we will be following it up, those kind of patient. Steatosis on imaging with or without abnormal enzymes, without the feature of cirrhosis. Typically, you look clinically liver stiffness and measurement, suggestive of advanced fibrosis. If yes, then consider biopsy. If no, reevaluate after 3 to 5 years. If you have steatosis without feature of cirrhosis but persistent elevated enzymes, consider biopsy. If you find that there is a cirrhosis, consider stiffness measurement and consistent with cirrhosis, then initiate screening for hepatocellular carcinoma and vessel screening. If not, then if not consistent with cirrhosis, then consider liver biopsy. So that would be the kind of way we would be going ahead in this kind of patient. So what is the management strategy in such kind of patient? I'll have to be a little fast. There will be clinical risk assessment of the risk factors, non-invasive markers, and we will look for the. So what are the non-pharmacological approach? Non-pharmacological approach would be weight loss. 3 to 5% improves steatosis. 7 to 10% improves histopathology, including fibrosis. Exercise may prevent or reduce steatosis, and bariatric surgery is one of the important things. The best combined hypocaloric diet, that is 500 to 1000 kilocalorie less, plus exercise, independent macronutrient composition in diet is pretty important. So this is what happens, like if you lose weight more than 3%, there's improvement in steatosis. More than 5%, ballooning inflammation improves. More than 7%, NASH resolution, and more than 10%, fibrosis regression, typically what is being seen. Now, lifestyle is very, very important because most of the people don't do exercise, they skip exercise. 31% patient reported no recreational physical activity. A vigorous exercise, more than 75 minutes per week, associated with decreased odds ratio of NASH. OR is 0.65, so very, very important. Pharmacological therapy, whom to treat? Progressive NASH, bridging fibrosis and cirrhosis to be treated. Early stage NASH with increased risk of fibrosis progression, more than 50 years, diabetic metabolic syndrome, increased ALT to be treated. Active NASH with high necroinflammatory activity, NASH score more than 4 to be treated. So what are the treatment targets? Treatment targets are basically either you are targeting metabolism and oxidative stress, or you are targeting inflammation and apoptosis, or you are targeting fibrosis, or you are targeting gut. So you can target the bile acid, that is basically through the RXR receptor, that is the FXR receptor, and the drug that is obeticholic acid, which has been available. You can target the dietary fat through intestine. You can target on the PPAR gamma through pioglitazone or dual receptor, that is saroglitazar or lafebranor. And you can have the antioxidative kind of reduce the oxidative stress using the vitamin E or pentoxyphylline, or there are certain new drug in the pipeline like simtuzumab that is acting on reducing the fibrosis. Metformin, probably it is one of the drug typically in diabetic patient which has been used, and it was thought that it may decrease the level of enzymes and steatosis. However, several studies tried and failed to find improvement on the histological feature of NASH. It is not recommended as a specific treatment of NASH. Vitamin E, there has been study, that is PIVEN study, where 800 milligram of vitamin E has been used, and it has been compared with pioglitazone in the same study. So as compared to placebo, yes, there is improvement. But if you look at the pioglitazone versus placebo, you find that pioglitazone gives a better result. Pioglitazone alone in diabetic patient, there is improvement or resolution of NASH at 18 months typically been seen. That is more than 2-point reduction in NASH score, and the resolution of NASH in almost around 58% of patients seen with pioglitazone in this diabetic patient. Surgical management strategy include bariatric surgery, and you can see in the bariatric surgery done, there is improvement in the enzyme levels, also improvement in the insulin resistance index, ALT, GGT, everything there is a definitely, and the p-value is highly significant. And again, you can see over here the fibrosis score, there is a definite improvement in those fibrotic kind of score seen over here. Now, most important thing is there's a lot of new drugs which are coming, and as Kaiser said that in next few years, we'll have a lot many new compounds. So I'll just have a bit of thing on the new drugs, and this is just a comparison of those available drugs, that is key therapies for NASH. And you can see, like, as compared to the placebo and the active drug, the yellow one is the placebo and the blue one is the active drug. This is with vitamin E. You can see there is definite significant improvement. Pioglitazone 30 milligram per day definite improvement. Liraglutide 1.8 milligram, definite improvement. Obeticholic acid 25 milligram per day, definite improvement. Elafibranor, definite improvement. The newer drugs like Cinicrevok, there is improvement, as well as the bariatric surgery improved 60% at baseline and 10%. Resolution of NASH, again with the vitamin E, much better. Pioglitazone, good. Liraglutide, obeticholic acid, elafibranor, and you can see over here bariatric surgery. A huge improvement in NASH. You can see resolution of NASH. Improvement in fibrosis, again, yeah, there's an improvement with vitamin E, pioglitazone, liraglutide, obeticholic acid, elafibranor, no data. Cinicrevok, there is some improvement, and the bariatric surgery, definitely there is improvement in fibrosis. So there has been a study that is a lean study, phase 2 trial, which was done. And typically in the lean study at 48 weeks, you can see there was resolution. Here you can see 2 versus 9 patients. They had resolution of NASH, improvement in ballooning was seen, improvement in inflammation, improved fibrosis was typically being seen. SGLT2 inhibitor, which have a potential effect, it has not yet been approved for treatment of NAFLD or NASH, but since most of us would be treating diabetic patients, this is just I wanted to touch upon this. And the studies, they have shown that there is assessment done, and with the canagliflozin, the NASH back with the liver biopsy, and there was improvement in the lobular inflammation, ballooning, and fibrosis, which reduced by 78, 33, and 22% respectively, compared with the pre-treatment scores. Obeticholic acid, which has been approved very recently, and typically it is the pathogenoid acid receptor agonist, and which typically decreases inflammation and decreases lipidic cell activation, and which leads to decrease in the fibrosis. And the 25 milligram, which typically has been used, and it has shown that there is improvement in fibrosis and no worsening of NASH, which has typically been seen over here. However, certain adverse effect noted with the obeticholic acid, that is pruritus, increase total and LDL cholesterol, decrease HDL in type 2 diabetic patient, and there's some increase in the renal stone. Another drug to talk upon is saroglitazone, which is a dual PPAR alpha gamma agonist, which is again approved for diabetic dyslipidemia, and of late it has been approved for non-cirrhotic NASH in March 2020. There has been evidence the phase 3 kind of trial which has been seen. Silymarin, which is basically antioxidant, anti-inflammatory, anti-fibrotic drug, which is commonly been used, and it has found that significant reduction in fibrosis, AST, platelet ratio, and FIB4 score as compared to placebo. So these are the newer agent: elafibranor, aramcol, pentoxifylline, amrixan, Cinicrevok, solithromycin, fecal microbiota transplantation. These are the new possible treatment options which are available. However, most of the guidelines, that is ESL guideline, NICE guideline, and most of us follow ASSLD guideline, and they suggest that metformin, there is no beneficial effect. Vitamin E can be considered in some of the patient. PPAR gamma agonist, again like pioglitazone, in some of the study it can be indicated in biopsy proven kind of a NASH. Pentoxifylline, very limited data. GLP-1 analog, still data is very limited. Obeticholic acid, with the recent study, yes, there is some data. Statin, they are safe but not beneficial, which has been said in most of the guidelines. Liver transplant is the option for people where they go for severe degree of NASH and liver failure. Overall survival at 135 are similar amongst the patient who received transplant for NASH versus other etiology, but recurrent NAFLD occurs in 30% of patients by 1 year and almost 100% of patients by 5 years. So to summarize, it is a common clinical problem worldwide with significant impact on morbidity and mortality. Lifestyle modification is cornerstone of management, and despite active research, definite pharmacological measure to combat problem are still lacking. With this, I thank you very much for